It's my distinct pleasure to call this meeting of the Board of Education of Elizabeth City Pasquotank Public Schools to order. We will now have our Pledge of Allegiance by Cameron Rowe, fifth grader at Weeksville Elementary School, followed by a moment of silence.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty.
Thank you. Moment of silence. Thank you. Ms. Sawyer, would you lead us a roll call, please?
Dr. Donata Robinson.
Here.
Ms. Sharon Morton.
Present.
Mr. George Archuleta.
Here.
Ms. Virginia Houston.
Present.
Mr. Walter D. Jolly.
Present.
Ms. Pam Barretta.
Present.
And Dr. Sheila Williams.
Present.
Thank you. Welcome, board members. Ms. Warden, would you read our ethics awareness statement, please?
Welcome to the September 28, 2020 regular meeting of the Elizabeth City Board of Education. It is my duty to remind members of the board that it is your responsibility to avoid all conflicts of interest and potential conflicts of interest in accordance with Chapter 138A of North Carolina General Statutes. As public servants, it is your duty to continually monitor, evaluate, and manage your personal, financial, and professional affairs in such a way as to ensure the absence of conflicts or potential conflicts. Does any member know of any conflict of interest or potential conflict of interest with respect to any matter coming before the board this evening?
No.
And let the record reflect that no conflicts exist. Thank you, Dr. Robinson.
Thank you, Ms. Warden. We'll entertain a motion to approve the agenda as submitted.
Make a motion that we accept the agenda as read.
Second.
And properly moved in second. Any further discussion? All those in favor of the motion signify by aye by roll call.
Ms. Sharon Morton.
Aye.
Mr. George Archuleta.
Aye.
Ms. Virginia Houston.
Aye.
Mr. Walter Jolly.
Aye.
Ms. Pam Barretta.
Aye.
Dr. Sheila Williams.
Aye.
Next on our agenda is our ABC Science Collaborative. I'll turn it over to our superintendent, Dr. Edmonds, to introduce them.
Thank you, Dr. Robinson. Chair Robinson, Vice Chair Morton, and board members. It gives me great pleasure to introduce some folks that are with us this evening. They've been helping and assisting superintendents across the state as we're preparing for returning to campus. And I think we have with us, I see Dr. Smith there, and they will share with you what the Science Collaborative, the ABC Collaborative is. Oh, I think I see Dr. Benjamin as well. So I will turn it over to you all. Welcome.
Hey, great. Can you all hear me?
Yes.
Great. Thank you for nodding and for saying yes. So we do have slides if you all would like to bring those up. I'm sorry for joining late. We just got off an NIH call regarding some results that you all will be reading about in the popular press later this week. regarding a clinical trial unrelated to this effort here today, but I apologize for being late. So the ABC Science Collaborative was started by a group of Duke faculty. We've now been joined by University of North Carolina Chapel Hill and other academic faculty from other institutions with a background in medicine and in epidemiology and public health, et cetera. Next slide, please. And I may be on, there may be an echo for me. If that continues, I wonder if, I'm not on a second line. Maybe if other folks could mute, and if it really continues to be egregious, if maybe Mike can take over the presentation. So let me just start off by saying a few things that we are not. We are not here to give advice. We're not under any kind of illusion about making any kind of decisions. We don't give detailed advice on whether or not schools should move to plan A or to plan B or back to C, or how schools should structure their plan B environment, or that level of details. But rather, we're project, go ahead, next slide, please, is a three-part project. It's sponsored by the National Institute of Health. It now has 50 school districts involved in the state of North Carolina. We're expanding outside the state of North Carolina next month. It has three components to it. Number one is education. Number two is a data tracking app to ensure that students don't go to school with symptoms of COVID-19. And some focused research questions. For example, if we educate teachers and parents through webinars, will there be greater uptake in participating in public education? The other part of leadership focus actually surrounds our work with superintendents. And there, our role is to educate and equip superintendents around the details of the science that they can make well-informed recommendation to their school boards. Am I having too much of an echo for you all, or should I keep going? Anyway, so that they can make detailed recommendations to you all. And I'm going to give you some examples of how those recommendations, how that education with superintendents goes, and so that you can get a good feel for that. Go ahead, I'm not going to read through all of these slides to the school board. So this example that we've been given to superintendents compares an overnight camp in Georgia with one in Maine. Now, this first overnight camp in Georgia started in mid-June of this year. They had an orientation for 138 trainees and an additional 120 staff members. The median age was not too dissimilar from what's seen in the public school environment, with a median age of 17, and age up to 59 years, not dissimilar from a public school. There's limited cloth mask compliance, and masking was not enforced at the camp. And although they tested people, they did so up to 12 days prior to arriving. They were joined a week later by 363 campers, all school age, 6 to 19 years of age. Vigorous singing and cheering, indoors and outdoors, and masking was not enforced. On June 23rd, the first teenage staff member had symptoms and was tested positive for COVID-19, and I think you all know where this story is headed. Next slide, please. So the attack rate ended up being, before all was said and done, about 50% in the nearly 600 people at this overnight camp. Equal distribution between male and female. At this point in the summer of 2020, there was some speculation in the medical community that children did not transmit COVID-19. Turns out that speculation was not correct. The trainees of all ages were getting infected, as well as campers and all staff. The children were in cabins. These range from very small to larger than 13 students per cabin. And not a surprise, in the cabins with more students, there was more transmission, but it was considerable transmission wherever the children were housed. And really, it was all about not masking. Go ahead, next slide. So the key points from this overnight camp in Georgia: masks are important for children as well. Children should be wearing masks. Although most of the transmission occurred from staff to campers, camper to camper transmission occurred. And of course, the longer one was a camp, the higher the risk of the infection. Next slide, please. So in Maine, this is a story of a camp where things went well. This was in the MMWR, or Morbidity and Mortality Weekly Report, the journal from the CDC. Now, in this particular camp, they tested the children at the start. They cohorted the children at the start for 2 weeks, much like one might do in an elementary school. And they were fastidious in their masking and in their compliance to masking and in their distancing. And in 4 overnight camps with over 1,000 students from over 41 states, there was no secondary transmission. That is, there was no camper to camper transmission despite spending the night with each other for weeks at a time over the summer. And folks have said, well, perhaps it was because it was a rural camp in Maine. However, these children were coming from over 41 states, so they really reflected the national average for COVID at that time, which was a higher rate than it is in North Carolina right now. Go ahead, next slide, please. So what do we learn from this? Well, this fits into a series of data that we presented to the superintendents over the last couple of months, where we've emphasized that whether you're in a camp experience, Maine versus Georgia, or what we've seen locally or throughout the Southeast or throughout the Northeast, masking and distancing and hand hygiene are really important. It's not the rate of infection that's in your community that's crucial. It's your plan and adherence to the plan around the 3 public health imperatives. This has also been replicated in the child care experience, where things were done well in New York City, and things were not done well in Utah, where there was no masking, and pre-K children had a large outbreak in the Utah child care. Staff members were impacted as well. It is also consistent with the university experience. So in universities where masking is not strictly adhered to, and young adults are allowed to go off campus and engage in a mixture of legal and illegal activities in bars and social fraternity houses, things do not go well. In universities where there is strict compliance with hand hygiene, masking, and distancing, we're seeing a very, very good control, whether that's at Davidson or Duke, Norwich, which is at 0 cases over the past 8 weeks, despite those undergraduate students actually sharing dorm rooms. And as that happens to be a situation where the kids have actually moved multiple times within the dorms and they're still not getting infections there. Western Carolina is actually doing a pretty good job locally, not great, but pretty good, because they're doing a reasonable job around masking. Right now, some of your peers around the state that are in the collaborative are open and doing quite well. Yadkin County Schools has given us permission to talk about their experience. They've seen 0 secondary transmission in the hybrid environment. Same with Iredell, Statesville Schools. Yadkin County Schools is a little bit larger than you all, and you all know better than I do. Iredell, Statesville is considerably larger. than ECPPS schools are. The key elements here are really around masking, distancing, and hand hygiene. Metrics such as the fraction of percent positive tests can be a small part of the decision, but it's really around what I would call to almost a contract situation, where in broad strokes, the district sets up a plan. The principals at each school ensure that the plan is adhered to, and that the community, that is the parents, the families, the students, the teachers, come together and adhere to the plan. And really what we're looking at here is a risk-benefit decision for y'all. Because either way, this fall in ECPPS school district, infections are going to happen. If you're all remote, they're going to happen. And if you're in school, they're going to happen. The key for the school district is to make sure that to limit the amount of secondary transmission so that being in school is not substantially greater risk than remote learning. And early data thus far strongly indicates that that is possible, provided that masking compliance is at the level of 99% or greater. That means every human who comes onto school property at all times is wearing a mask. We can talk separately about the adaptive curriculum. There's some additional data there that I can share with you all. This is less robust than what than the experience in the mainstream curriculum, but just as encouraging. The 99% masking compliance rate and greater that you're going to want to achieve, you'll do that with hand hygiene and distancing. The school district can succeed in the hybrid model. We have less data around, obviously in North Carolina, we don't have any yet around Plan A. There's some extraordinarily modest data around the success of Plan A in other states, not nearly as robust as the hybrid model data. Go ahead, next slide, please. Again, these are the districts where we have memorandums of understanding. Obviously, one of our partners is you all, and we're grateful to be working with you all and the thoughtful staff that you all have in the superintendent, with the superintendent and with her staff working together with us. Mike, if you've got stuff you'd like to interject here, if there was items that were not clear because of the echo, go right ahead. Otherwise, I'm happy to take some questions.
No, thank you, Danny. I think you got the key points. Why don't we see if there are any questions? You were easily understood.
Great, thank you.
I have a question.
Yes, sir.
Are you recommending that we take temperatures as well?
My understanding is that DHHS suggests that you all take temperatures. I don't want to get in the way of that advice. Dr. Edmonds, is that suggestion from, I'm working with a number of states. That's why I'm shaky on this. It varies by state.
Yeah.
I think DHHS wants you all to take temperatures.
Yes. Once
Okay.
anyone that enters into the school building, we would need to take their temperature.
Great. So the most common question that I get in a state like North Carolina, where temperatures are required prior to school entry, is, should we take temperatures on the bus? And that might have been your question, and I just didn't hear from echo. I've gotten that question a number of times. In general, I would encourage folks to think about the limitations of taking temperatures prior to taking temperatures in a school bus environment. You have a couple of options. You can take them at the school bus, you can take them at the schoolhouse door, or both. Because you're required to take them at the schoolhouse door, I would encourage you to think through some of the drawbacks of taking them on the bus in addition to at the schoolhouse door. Some schools in North Carolina consider that. The disadvantages of that approach are as follows. The external thermometers are very inaccurate. They pick up a lot of kids that don't have fever. They miss a lot of kids that do have fever. Fever is usually not an early finding, is usually not a finding in COVID in children, and is usually not an early finding. So a negative temperature does not reassure you, especially as it gets cold on those buses during November, December, January. That temperature reading is going to be very hard to rely on. And then what you're going to be doing in these buses is the kids who get on the bus first, it's going to take your bus driver additional time taking these temperatures. That does two things. First of all, it detracts from the time in instruction, which tends to be important to teachers, administrators, parents, and school boards. It detracts from the time of instruction because it takes time to take all these temperatures. But more importantly, from a public health perspective, it's not an accurate test. And children who are on the bus waiting for other children to get their temperatures taken are standing or sitting in relatively close proximity to each other, waiting for the bus to go to school and doubling the length of time it takes for your bus to do its bus route. So I don't want to say don't do it, but I would encourage you to think carefully through the marginal benefits and the non-trivial risks of taking temperatures on the bus.
I have a follow-up question. Thank you.
Yes, sir.
What is the benchmark or what is the temperature that would have a person be allowed to come to school or not be allowed to come to school? What would that temperature be?
I'm going to refer you again to NCDHS guidance because I think that also varies from state to state. If I had to guess, it would be 100.4, but I don't even want to venture that guess. Dr. Edmonds probably had that number, or Mike is nodding his head. That may be a good sign. I'm at least on the right track.
Yeah, I'm on Google, Danny. That's what I'm doing.
Oh, great.
to see what
Thank you for that,
to
Mike.
see what DHHS does say. Because I agree with you. I think clinically we have one thing in our heads, but
Right.
we should see what the rules are.
And really that also varies by state. So it really doesn't matter what I think here. This is something where my suggestion is you just be in line with DHHS.
Thank you.
Because there's no sense in me telling you the number in Texas and you adhering to that if it's not North Carolina. Other questions? Both of those were very, very thoughtful, very good questions. Thank you for asking them. Other questions?
I have a question. If temperature is not an early indicator for children, what is?
Well, the substantial fraction of folks are going to have no symptoms at all. In fact, it's about half, especially for younger folks, and in fact can be more than half never have symptoms. And this is why the masking is so important. Back when we were dealing with SARS in 2003, which is a different coronavirus, it's kind of a cousin of COVID. We could just tell people, if you're feeling sick, stay indoors. And that burnt out in Toronto back in 2003. COVID is much sneakier. About half people don't ever develop symptoms, and the vast majority of folks, at the very least, go through days of having no symptoms. and yet they're infectious during that time. So that's why masking is super critical from a public health perspective to have control over the pandemic. Children will have a lot of non-specific findings. Those will overlap with flu, kind of muscle aches, feeling lousy, some GI, gastrointestinal distress. They'll also develop some cough. So it's really very, very difficult to differentiate COVID-19 from flu at any age, especially in childhood. The one unique symptom with COVID-19 tends to be loss of taste or smell, but that's just not in a high enough number of patients. And it's too late by the time you get it, because by then you will have exposed and infected a substantial number of other people if you've been wandering around in a public setting with a mask on. So again, very, very good question. Very difficult for y'all to tell the difference. And this is why this year, this is a great year for ECPPS to really push for the flu vaccine this year among teachers, families, and students.
I agree with that 100%. And just to, I was doing some Googling while you were talking. It looks like the North Carolina DHHS uses 100.4 Fahrenheit as the cutoff for fever.
Yeah, that's a lot of the states have chosen that number. Other questions?
So I know we talked earlier today, and it's something that was a little shocking to me that I hadn't thought about, was the question around, do children get mask breaks at lunchtime, serving the lunch to them in their classroom? What should that look like? And Danny, I think you went into very detail about what that should look like. And I thought that was pretty interesting, that maybe something you would want to share.
Yes, ma'am. I'm happy to do that. There's one or two things, and I probably would be wise for me to talk about how we're taking care of patients in the hospital environment so that your school board members have a good perspective on that as well. Let me get to the lunch example first. So this is being used in several of you by your peer groups. The 4 times that I encourage math breaks around school: before school, after school, while drinking water, and lunch. Okay. Otherwise, while you're on school property, wear a mask. We'll get to the adaptive curriculum here. I promise to cover that after I cover the hospital setting one. All right, so the part of the reason for that being so tight around that is public health interventions are not complicated. It's not quantum physics. It's not even second semester calculus, right? It's just masks, hand hygiene, 6 feet apart, okay? But what public health relies on is extraordinarily high compliance with that. And what humans rely on is consistency in telling them to do that, especially children. Now, at lunch, what many of your peers are doing is they're having the children go to the cafeteria or to their lunch bag or their lunch box. They get their food, they bring it back to their desk. All of this time they have masks on. They unwrap all their food, they cut up their apple, they cut the crust off their PB&J sandwich that mom made for them. They open up their milk carton. They do whatever they got to do to get all their food ready. The teachers then say, okay, hand hygiene. They scrub hands with hand sanitizer or what have you. They take off their masks. They then have 10 or 12 or 14 minutes to eat. They're 6 feet apart at this time, at least 6 feet apart. No talking during this time. Just eat your food, get your job done. And then at the end of that time, hand hygiene, mask back on, and then we can go and have fun. The reason for this is if you can keep the kids less than 15 minutes, they're not going to have kind of that meaningful exposure cut point that CDC has defined at 15 minutes. We also find that when we've seen, in the rare instances where we've seen secondary transmissions in work environments where there's a lot of masking going on, it tends to be in break rooms where people take off their masks, eat a prolonged lunch for 30 or 45 minutes with their mask off, talking with their colleagues. I'll get to that in a minute in the hospital setting. So that organized lunch is something that your peers have been using to good effect. That brings me to hospital. So one of the things that I think a lot of worried parents and staff have been seeing are kind of pictures in the New York Times, if you will, or the News Observer, with people wearing what amounts to spacesuits in the hospital environment. It's actually not how we're taking care of patients who are in the setting of no symptoms and either a negative COVID test or the children who have not been tested. So for months, we've been admitting patients to the hospital without routinely testing them for COVID-19. They're coming into the hospital, those children, or on the adult service, those adults, they wear a cloth mask. As a faculty member, Mike or I visit them, and we wear a mask that's either cloth, or these days there's now enough masks in the hospital that we wear a medical mask. Not an N95 mask, just a routine medical or surgical mask. When children cannot mask, this summer, what the faculty did was we could wear eyeglasses. So I would borrow my wife's reading glasses, and I would put my wife's reading glasses on and put a regular surgical or regular medical mask over my face. In late August, Duke required that we move from the eyeglass to face shields. That's what we've been doing for the last month or so. All right, in that setting where the children are wearing a cloth mask, I'm wearing a cloth mask or a medical mask, and in March and April, we didn't have enough medical masks to go around. When children are wearing a medical mask, a cloth mask, and I'm wearing a mask, there have been 0 cases of documented transmission, secondary transmission, 0 cases when people have adhered to the protocol. Secondary transmission has occurred when staff break protocol, go into a break room, take off their mask, and eat lunch with each other or talk to each other at length, face to face, without their masks on. Those are the documented cases of secondary transmission that we've had at Duke. Duke has 30,000 employees, and at UNC healthcare system. That's also true at most of the other hospitals throughout America. So we're practicing in a way that's very similar, nearly identical to the way your teachers and staff are going to be executing their craft, that is instruction. Now the adaptive curriculum, and I'm sorry for going on and on like this, so somebody text me if my answers, if it's too painful for you, just give me a text. The adaptive curriculum is where we're seeing some challenging around masking. Your peers in rural counties throughout North Carolina are achieving a masking rate in that group of students of around 50 to 80%. And of the children in that adaptive curriculum who cannot mask, approximately half are able to tolerate a face shield for at least part of the day. In that setting, I would have your teachers wear a medical mask and a face shield to give them extra protection. A face shield is not a substitute for a mask, but it's helpful, especially with children who cannot mask and maybe don't have 100% control over body secretions. It's also good, obviously, for those teachers to, whenever possible, be 6 feet or more apart, which is not always possible in the adaptive curriculum, but to the extent that they can, that's helpful. This means that on average, your peers in rural North Carolina have approximately 1 student per 1,000 that are coming to school unable to mask in the school district. So in a school district like ECPPS, 5, 6 students is what we're going, which is what we're going to be looking at. If you're in a situation where you're hearing reports of more than a dozen students across the county not adhering to masking, that's something where we want to look into that. We want to take a real critical eye at what we're doing there. It may be that you have a very, very high fraction of students in the adaptive curriculum, but you at least want to know that's the case. Is that helpful?
Yes.
Yes. Any other questions?
Good information.
Thank you very much, sir, for sharing with us this evening. We're about to make a decision about re-entry to school, and this information has been very helpful, so thank you.
Absolutely. And then our project leaders will be in touch with with Dr. Edmonds about making sure that she and her team and your teachers and the school board and your parents have access to the webinars that we're doing. We're doing those once a week. Those are recorded every Wednesday night. We can provide continuing education to teachers that sign in for that. We answer a lot of questions like the ones you all have. Those webinars are stored on site, and I encourage y'all to look at those if you have a spare time. Thank you for partnering with us. We have a lot of respect for what you're doing. We know you've got real difficult decisions in front of you, and I'm hopeful that we can help you in the best way that we can. Thanks for having us.
And thank you, and please stay safe.
Yes, sir.
Thank you all.
Bye-bye. We will now recess our open session. And Pam, would you take us in the closed session, please?
Yes. The board will go into closed session for the purpose of considering personnel actions that involve employees of this board as allowed by NC Statute 143-318.11A6.
We will now have a motion in the form of aye with our roll call.
I move that we go into closed session.
I'll second.
Sharon Warden,
Aye.
George Archuleta,
Aye.
Ms. Virginia Houston,
Aye.
Mr. Walter Jolly,
Aye.
Pam Pereza,
Aye.
Dr. Sheila Whittle.
Aye.
We are now in closed session.